Good afternoon, everybody. Thanks for coming to this Dean's Lecture. And as you all know, we hold these. Hey, Mark, how are you? We hold these to celebrate the appointment or promotion of a person to the rank of professor. And as I say, it's not easy to get on our faculty. It's a really high bar to be promoted to professor. And that's a decision that's made not by us or by the department chair or the committees. It's really made by peers around the world who write in. Now, I say that about Eric Ford, but he's been promoted to professor lots of places, and I'm sure this is not the first Dean's Lecture that you've given. And so many of you in the room know Eric, but I'll just tell you a little bit about him. We are so delighted that that the department was able to recruit him to head our Masters of Health Administration program. Incredibly accomplished, and I'll just tell you a little bit about his accomplishments. He came to us from the University of North Carolina at Greensboro at the Bryan School of Business and Economics, where he was the Forsyth Medical Center Distinguished Professor of Healthcare, and he was there for about 5 years. Before that, he held an endowed professorship at the Jerry S. Rawls Professor. He was a Jerry S. Rawls Professor at the Jerry S. Rawls College of Business at Texas Tech. And there he was Program Director of Health Organization Management and Director of the Center for Health Innovation, Education, and Research. He also held an adjunct associate professor appointment in family medicine in the School of Nursing and in the School of Nursing. Prior to that, Eric held the Humana Research Fellow, which is an endowed professorship, in the Department of Health Policy and Administration at the College of Health and Human Development at Pennsylvania State University. Before that, he was at the University of Alabama School of Public Health as an assistant professor in healthcare organization and policy, an assistant program director and internship coordinator at the Culverhouse College of Commerce and Business Administration. As I said, here at our school, he directs the MHA program, and he's an associate chair of the Department of Health Policy and Management. It's hard to encapsulate all the things that Eric does. And I'm just going to talk about the academic things that he does, but he does many things, has done many things outside of academia. But he's interested in strategic management, health information technologies, innovation, and the combined effects on performance, both financial and related to population health. In particular, he's focused on the link between personal health record use from the consumer's perspective and their impact on health. Besides his focus on healthcare research, he's currently working on the Mobius Social Learning Information Platform. I don't know if you're going to talk about SLIP here. No, okay. To promote peer-to-peer engagement online. His research interest includes both information systems, machine learning, natural language processing, and how they are used to improve student social interactions. Eric and his research group from other universities were awarded a National Science Foundation grant to advance the Mobius SLIP in 2014. He's published widely, well over 100 publications, and has a great impact in the professional societies related to management. So we were very fortunate to recruit him, especially because the first thing he had to do was to do the accreditation of the program. And so that's always fun to really learn the program well from day one, and to recruit other faculty. So Eric, we're looking forward to talking and both congratulate you on your appointment, and we congratulate ourselves. So.
Thank you. Well, thank you very much, and I can't tell you what an honor it is to be here. I suspect if you could go back 30 or so years to a fraternity house and ask the brothers which was the lower likelihood that Eric Ford would be honored at one of the world's most prestigious higher education institutions, or that he would be blocking people's way to the bar, I suspect the former would be... I am doing both, I understand, and I shall try to rectify one of those at the very least. I can't thank all the people who've made this possible, from dissertation chairs and committee members, colleagues, not least of which my family, who have endured many moves, as you've rightly noted, including long hours of me doing the work I love, often at their expense. And I'm eternally grateful to their willingness to let me pursue this endeavor with my full heart and being. And I couldn't be more delighted to be here at Johns Hopkins, in all sincerity. Today, I'd like to talk to you about a couple of my passions, which are information technologies in general and health IT in particular, and where it's going and how we might make it better in our U.S. health system over time. And I hope you'll enjoy some of this. I'll try to make it fairly simple. I'd like to talk a little bit about innovation science. We hear so much about disruptive innovations and how the world is changing so quickly through driverless cars, et cetera. But we often don't study innovation as a science or think of it in those ways. So I want to try to reframe the way people normally think about it. I also want to talk about health information technology and its history as a policy endeavor, and talk about the current state of the art and where it's going, and actually give you some sort of commentary on what I think the U.S. health system can do to be better about its use of health IT writ large. Okay. So a quick primer on sort of the technology diffusion and the theory. Many of you would be familiar with the work of Rogers, who talked about innovators, early adopters, the early majority, the late majority, and the laggards or Luddites who simply never adopt a technology. And he's fairly famous. A lot of that work was later picked up by Frederick Bass, who actually modeled that, and some of the work I'm going to show you here today is actually fairly an extension of his early work. And a bit about how it talks about it. The way we study innovation as a science is we try to think about what are the internal components that motivate people to adopt a technology, and what are the external influences, the marketing, the policies, the other things that we can use to actually influence people to behave the way we desire. Okay. So I'll ask you a quick question. Does anyone know who bought the first fax machine? Joe Fax. Yeah. And I actually do know, but the answer is the same person who bought the second fax. Because what's the purpose of having one fax machine? And a part of this is a lot of the innovation. The reason I bring this up are networked. If there isn't a social relationship and people connecting around a technology, it often isn't picked up. So that's one of the things to think about as we go forward. I didn't know if any of our colleagues from epidemiology or biostats would appear, so I felt compelled to make sure that somewhere there was cryptic-looking equations that they could chew on and later query me about. And I mentioned earlier, P, you might think of P, the coefficient, as the policy coefficient, if we're going to talk about this in a policy context. And this often talks about the external components, whereas the Q variable will talk about the internal motivations for people, and we look at things over time. In the classic sense, when you think about Rogers, this is sort of his graph. And this is the cumulative adoption, by the way. You'll see the innovators are early on. Then you have the early adopters. And in between the early adopters and the early majority is something that's called the innovation chasm. A classic example of this is Betamax, which Sony put out and was a superior technology in many respects for viewing video. However, it never managed to cross the innovation chasm, and instead VHS came along and became the dominant form for many years. For those of you who now Netflix and chill, you don't know what I'm talking about, but there used to be something called video, and it was very popular, and it looks like this. And since I'm going to talk today about information technology, I want to bring it back to the most common form of information technology we all use, and it's the telephone. And you know, around 1920, the phone was actually built in 1877 thereabouts, but it only gained widespread use because the network was built out around the 1920s. And it looked like something like that. This is called a candlestick phone. You'll notice what it's lacking. There's no dial. You had to pick up the receiver, you'd click on the side, the operator would come on, one ringy-dingy, two ringy-dingy, that sort of thing. And you'd say, oh, I'd like to get in touch with Klondike 5, 3421 or whatever. And the operator would then take a cord, put it in a hole, and make the connection. And that was how you talk to people. And oh, by the way, in lots of old movies, there's lots of running gags about the operators listening in on your phone calls and directing you to different places. And you would have things like party lines where more than one person would be sharing a phone line, and all sorts of mischief would occur in your late 1940s movies. Later came something called the rotary telephone. And this was an innovation both in the user interface, these are the user interfaces you're looking at, but also at the system that underlies the telephone. And it was automated switching, so that when you actually put the numbers in, it sent your call to whatever was supposed to be at the other end. I actually told this to my strategy class. They also introduced area codes at this time. And if you want to know what the most populous cities in the United States were, take a rotary phone and dial the area codes, and whichever area codes have the least distance to dial were the most populous. So New York is 212, and 1 was not allowed as a first digit. So that was the most popular thing. By the way, these would often be one in a household. If you go look at houses from the 1930s and 40s, you'll often walk into the front door and there'll be a small alcove right next door. This was also a symbol of wealth and wherewithal, and people would have their phone sitting there for you to see. Okay. Next came this phone. When I moved into my house here in Towson, it was 1960 vintage and had not been touched. This phone was still on the kitchen wall, including all of the phone numbers written next to it, 8675-309, call Jenny, that kind of stuff. The cord was irrevocably knotted, as many of you know, so it actually reverted to being almost like this. And it was another system technology. All of a sudden you had push buttons so that you could call a number, and many businesses would then have something like, to call billing, press 1. To call new services, press 2, and you would get the phone trees. And we even had things like in the late 80s, you would get buttons like *69 where you could dial the number back to where it came from, or those sorts of things. It was a wonderful era. I can remember in middle school, my sister was the only person who ever used the phone because she was always on the phone. And it was big news when Dominica Sabella got her own phone. A middle school girl got her own telephone. Why? Because her parents wanted to use the phone occasionally. So, but you'll notice what's happening in these curves. Unlike this curve, where you assume a technology comes along and is what we would call the archetype, the first and last iteration of a technology, meaning the first version that comes out is the last version you'll ever need. And that's what this curve would look like. But the reality is, these things are replacing one another. The rotary phone replaced the candlestick phone. The push-button phone replaced the rotary phone. And then you get a new technology comes along, mobile telephones. And this is actually a picture of the Motorola StarTech, which was the first phone that really didn't have to be housed in your automobile or was the size of a brick and required some guy standing behind you to holding the phone, battery, those sorts of things. And it was very popular, and it was called the StarTech. Why? Because it looks like the communicator from Star Trek that many people. And again, this is a change in the underlying technology. We had mobile technology now that was available, and also the user interface. Many of our students today will have cut the cord, both literally and figuratively. In other words, they will not have a landline coming into their house. Why? They don't need a landline coming into their house. And of course, there is another technology that's come along, and I'll ask a few of you to think about, what is your level of connectivity? I'm going to take it as a moot point that everybody's got one of these. No? Okay, so we've got one person not on board. 2? Oh my. Well, this is great. We'll actually get some variation in our sample. So I will start to ask, how many of you have one of these devices? So either a counter or an iPhone, a Fitbit, a Nike Fuel. All right. So this is another example of how one technology builds on the other. So in order to have some of these that actually function right, you need to have the phone that goes with it. One of our colleagues, Jonathan Weiner, actually has 2 Apple Watches, and I'm just waiting for the day when he's talking to himself on both hands. But so you might be a slightly more complete user of this technology, if you want to think about it this way. And I'm going to start relating this back to both your personal health as well as the health system, by the way, because many of the technologies that we use in the health system build on one another in this same sort of way. All right? So now you've got a Fitbit, a Fuel Band, an iWatch, a Garmin, or some such thing, and then you have to put the interface, the application, to run with it. And this is one level of connectivity. How many of you are actively using your app interface to track your sleep, workout, heart rate, etc.? A few of you. So these are another level of adopters up the line. How many of you are using it to have competitions with other people on the number of steps, etc.? 1, 2. Occasionally, I actually manage to beat the Towson cross-country team in my number of steps. Of course, it's only on the days I actually run with them, but so I'm generally losing this battle. But that's another level of connectivity related to your IT and your health in this instance. There's even another level. Stanford has something called the My Heart Counts study, and they've asked us to connect our Fitbits, Apple Watches, etc., to their application so they can download all of our daily information. And they also ask us to take occasional surveys with them to talk about our diet, our sleep, and other things, and they'll actually ask you to do some exercises. And this is where, when we talk about health IT, you often hear people talk about big data. We're going to have all this information that we're going to be able to run through machine learning, artificial intelligence, and we will know the most obscure way to fix the most rare disease. And that's the hope of all the big data. And by the way, Johns Hopkins, I just happen to be involved in the Stanford one, so I have the pictures. Johns Hopkins has many of these already underway, and one of the more interesting ones is actually around epilepsy research. And your Apple Watch, if you have epileptic seizures, can actually predict prospectively an event. And Johns Hopkins is actually struggling with the FDA because now it's almost becoming to the point where what's normally just an app and information is suddenly flipping into medical device potentially. So it's a very big challenge. So that's how to think about your phone. And let's think about electronic health records. You know, I look back and I try to figure out, when did the government really get interested in this? And in 2001, a book that I'm quite fond of that talks at great length about complex systems and networks and how to fix our health system, and points to much of the good work that are done by our colleagues across the university here, including people like Peter Pronovost working on his sorts of fixes to the health system. But this Crossing the Quality Chasm, the title was designed to invoke some of what Rogers talked about, where innovations also have this chasm. And why? Well, the point was there were many health systems that were delivering high quality care in a thoughtful manner, but they were the innovators and early adopters, and that's where it tended to stop in our health system. And too many hospitals and too many health systems were not adopting what we knew to be best demonstrated practice or empirically demonstrated practices that would help save lives, improve the quality of care we deliver, and generally improve the work life of all involved. In this book, though, there's no EMR reference at all in an explicit sense. They do mention in passing, they have about 4 pages dedicated to clinical decision supports. but I would tell you the way they describe it is not in any way, sense, or form the way we would think of computers today in clinical decision support. The other favorite quote in here is, they predicted the internet would be promising. So good for the folks there. The other book that gave rise to the quality chasm was, of course, this seminal work, To Err is Human. In 2000, came out the year before, and there's no mention of EMR or CDSS, clinical decision support, throughout this book. Now, these are two books, if you walk around the health policy management department and walk into any faculty member's office, I'm guessing you're going to see both of these books. My question then would be, how many of our faculty have this book on their shelf? If you do, this is probably sitting next to your Honus Wagner baseball card, your Marvel Comics 1 Superman, because it's that rare. I don't think many people read this. I think it had I actually went back and researched this. It had an initial run of 150 print. So talk about a bespoke journal. You can download it now for your Apple Reader, though, by the way. And this was in 1991. And they were calling for, in 2001, everybody to have a computer-based patient record. So even the name is sort of archaic. But they were way ahead of their time. And this book continues to languish, and probably should. I mean, it's not truly relevant today, but there were certainly people who were thinking about it. And through none of this did the government, the federal government in most forms, act on the information. ARC, NIH, NSF, and of all those agencies, by the way, NSF probably funded more research into health systems, IT systems at that point. And even that was so minuscule as to be laughable. It wouldn't fill up one faculty member's requirements here, probably. So who did start it? Well, somewhat surprisingly and out of left field when he announced it, the second President Bush in 2004 came out with an executive order, and if you read the wording of this closely, he says every American should have a personal health record linked to their health system by 2014. And I think the important point here is personal health record. I've asked you about your phones, and he's telling you now about personal health records, and that was the vision. And he created something called the Office of the National Coordinator for Health IT, the ONCHIT. I've often thought I should start a consulting practice that does nothing but help the government pronounce its acronyms and think twice about some of these. The first Office of the National Coordinator person was Dr. David Brailer. He was given extraordinarily high expectations. He was being held responsible for a great many things. He was being given negligible to zero budget and almost no authority. Not the ideal managerial situation, to be sure. And this persisted for several iterations of ONC leadership until the crash, 2009, thereabouts. And at that point, the American Recovery and Reinvestment Act funded fairly significantly the introduction of something called the Meaningful Use Program. And that was a very interesting program that is, and I'll talk more about it toward the end of the lecture and throughout here. But so that's how it was created. One of the challenges we have in healthcare, though, is suddenly when you go to the policy wonks and start talking about health IT, everybody's inner Trekkie comes out and they become futurists and they talk about health IT in terms that just aren't in touch with the reality of the technology that we currently have available to us. And I would tell you the three largest vendors of electronic medical records to hospitals are actually operating on database management systems that are 2 or 3 generations behind the sorts of organizations you would envision being on the front edge: Amazon, Google, Alphabet. I would also tell you that they, in terms of their user interface, are behind the times. They do not do what's called A/B testing, where we give you 2 alternative screens and see how you use them, and then the one you use more of we then implement as our system, and then we go back and create another B and start iteratively improving. They don't generally have dynamic functionality, meaning if you're a physician, a nurse, a pharmacist, an allied health professional, once you step away from a computer and pick up something like an iPad or a smartphone, the screen does not dynamically change to bring the information into the format you're currently viewing it. I should say they've worked very hard and they've put some fixes in around this, but it's far from what we would normally expect in the applications we adopt in other places. And the last way that they are far from the state of the art is something called APIs, application interfaces. In order to monetize their businesses, they are blocking the data actively. They do not want people to be able to plug into the backside of their program and get structured data through the format of an API, the way most companies do. Google wants nothing more than for you to use Google Maps, Google Search, Google everything in your personal applications. If I wanted to load those into my learning platform, I would have the APIs this afternoon. They're publicly available, and I could build right into them. Healthcare vendors do not do that. Okay? So we are way behind, and our rhetoric is way ahead, and that causes lots of problems. So this study at hand, and I just want to show you some of the current research we're doing, and we're very proud of this. I'm doing this with Tim Huerta and Claudia Gonzalez. Claudia Gonzalez recently took a job working for the director of the NIH, so we're very glad to have that relationship and somebody, hopefully, who can get our message into the NIH that we need more funding in this domain. And Tim Huerta is a faculty member at Ohio State University, and they have many things in common with us. But we use the data from HIMSS Analytics, and HIMSS Analytics had a very nice model where it's designed that if you're at stage 2, it's logical that you would have had to have implemented everything in stage 1. In other words, you probably can't be at stage 2 without stage 1 having occurred. Therefore, you get a smaller and smaller slice of healthcare. Currently at stage 7, there's something like 20 organizations that have actually achieved stage 7. 100 or so that have achieved stage 6, etc. And so this is like the phone again, though. Stage 1, we see a few people doing it, and then they get bought out, and stage 1 should eventually tail off as something that people are engaged in. In other words, it's like the candlestick phone. Yes, we know you've got it. The connection should go away. Okay. Oh, that one got a little bit out of order. So here's what our slides look like as we look at these various stages. And here I've got some color ones. This is stage 4, which is in effect meaningful use, which is the government's program, iteration 2. And we notice a few things about this stage. It's lower than a preceding stage, and it's also lower than a successive stage. Okay? And this is an indication that hospitals are actually leapfrogging this technology. So for those of you who buy iPhones, or what have you routinely, I'm currently on the series where I get every odd numbered phone. My telephone plan says every 2 years you can come back and get a new phone, so I have a 6, the 7 will come out, then I'll get an 8 years down the line. And that's called leapfrogging technologies. And we often see people, many people had rotary phones for many, many years after push-button phones became available, for example. Okay. And then again, as I mentioned, stage 5 comes along and exceeds it. Now, stage 5 is what was going to be, by and large, meaningful use stage 3. The government has essentially put an end to the meaningful use program in the past 2 weeks, which is interesting in a number of directions. They've also made it so that the private practices that were in the medical group side of this can simply opt out almost in its entirety by, best I can tell, simply writing a letter and saying, I don't want to be part of it. So in a sense, the government's given up. And I'll be very curious to see how our models change going forward. But the other things to note are that stages 6 and 7 are not in any sort of technological time frame exceeding the old stage 3. So this is like everybody deciding that, the rotary phone was okay. It does everything I ever needed for my information technology. And that's a very disturbing message. And it's also a message, we can look at the cumulative adoptions of these two, and from its peak back at the lower technology to its peak at the better technology, we get a gap of over 1,000 health systems. A third. So which 1/3 of the health systems are we going to be underserved in, delivering lower technological levels of information? It's not clear to me, and it's very disturbing. And I should suggest that this was built on a model prior to last week. I think that the government backing off of its programs to advance the technology would probably open this gap up even further in the near future. And it's a bit of a troubling trend, to be sure. A lot of what occurs with personal health records, by the way, is in this last stage. The very last thing that most of these programs built into them was you, the customer, getting any access to your data or being able to share that data with other people. And the way caregiving is normally delivered, Jennifer Wolf does a lot of research in this area, is through family members. My wife tends to my mother-in-law's health care, and she has to have all of her logins, et cetera, to all of the websites to make all of those things work. And it's very troubling. And she can't get the full sorts of authority out of most systems to be a co-loggee into those items and look at them. And without the APIs that I've mentioned, there's not much industry. There's no other people out there, entrepreneurs, thinking, oh, I can build an app that'll allow you to pull in your record and act on it. It's very troubling. And the sad part is, and we've got a paper, and I just found out today, at JMIR that we published in collaboration with people at the National Cancer Institutes, that we looked at the diffusion of innovation of PHRs. And this was based on consumers' desire. And the fact is, most people want to have interfaces with their medical record. They want to have some access and control that's meaningful, not just pressing a blue button, which is what the VA did, that creates a PDF that's almost unintelligible, frankly, for the average person to interpret. Actual actionable data where you can engage your health system on your terms and have control of your data, and it's simply not coming. Again, PHRs are following a wildly different trajectory. It's challenging, don't get me wrong. Little organizations like Microsoft and Google have tried and said, it's much easier to put self-driving cars all over the world than it is to help people manage their health record. That's how burdensome we've made this application. In conclusion, the government's efforts were long in coming. They could have started earlier, invested in research, invested in the Veterans Administration, which at one time had a very fine electronic medical record that had many of the characteristics that were desirable. It was open sourced, so people could look at how it functioned, emulate it, adopt it, improve upon it. None of those things exist in the current market for large integrated health system electronic medical records. When the government did get involved, it was a little late, and it was probably overmanaged. Simple rules would often drive better innovations rather than dictating a few very specific functionalities in the approach that was taken. And as it turns out, not all great ideas can be crowdsourced. In many ways, you got something that looked like a committee in terms of its policy, in that it was disjoint, did not take in the technical realities of implementing these systems or the logical progression of implementing them in a health system. And it was very distressing. And I think that we're going to live with the legacy of that for quite some time. Many health systems are now married to these vendors. They simply do not have the capital available, and they probably can't store up the capital to switch vendors at this juncture. So these are going to be marriages of inconvenience. We've also de-incentivized the major vendors from sharing, perhaps from innovating, et cetera. It's been very troublesome to see the state of affairs, and now that the government is essentially washing its hands of it, it's not an opportune time for that to be happening when we have so much promise and we have so much ability and it is so close. And the good thing is, in the same way that the space race created plastics, integrated circuits, and other things that we live with today that make your mobile phones work, for example, and the glass, the needs for computer science, informatics, population health informatics, and the sorts of technological advances that healthcare needs to make function would have so much benefit in so many other sectors of our economy. It is just remarkable, and this would really be the next space race if you wanted to invest in an innovation and development area through science and better science. Thank you for your time.
Well, thank you, Eric. That was a really interesting talk.
Oh,
So not everybody probably knows about meaningful use, and so meaningful use was a term that was put in the High-Tech Act that required health systems to install electronic health records. And then there was a committee, the On-Shit Policy Committee, which I was appointed to. And so I was on the committee that was charged with developing the meaningful use criteria. And so that convinced me that I would never have a career in health policy. I mean, it was to be in the middle of that. And so you cannot imagine. I mean, these decisions drove billions of dollars of expenditures. And I just got back from Indonesia, so I saw the headline that meaningful use got axed. But I have to think that's because the cost of implementation, both in terms of outlay and then the resource, they're incredible. But let me tell you how those criteria were developed. There were 3 or 4 people on that committee that drove everything, and they would sort of wake up in the morning with an idea, and they would say, I think we should do this. And I can remember at one committee meeting saying, so meaningful use, there were a series of 3 stages, there were a series of criteria. So one criteria was a good one. It said within 48 hours, you need to have access to your health records. And you could do it by logging in, you could do it by an email. There were some good things there. But one of the I think it was stage 2, there were these quality metrics, right? So you know much more about quality than I do. I'm sorry to get up on the stove. I've never spoken about this in public because it's such a painful experience. But there are whole organizations that develop quality metrics. So they decided, we'll develop our own quality metrics, right? And I said, well, look, I don't know anything about quality, but I know there are lots of metrics out there. And so they were developing sort of willy-nilly metrics, and then CMS would have to operationalize those, develop criteria, and then a place like Hopkins would have to spend $1 million auditing it, right? So I'm happy in one sense. You seemed a little sad that there's going to be, but I think meaningful use was not well done. It wasn't well done, but if we lose the ability to, and you sort of portrayed vendors, a little negatively in saying that they don't. It's not vendors who don't want to share information. It's health systems who don't want to. The University of Maryland doesn't want to make it easy for Hopkins to get those records, and vice versa, right? So I think but if you look at who won, right, the big vendor is like the most liberal, non-business, Epic. I mean, they're in a sense don't care about money. I mean, so it's ironic. But anyway, sort of a comment about that. But I think meaningful use, you know, it was not a, you know, and the other thing that happened, I'll end with this again. The other thing that happened is that Bush developed this committee.
Mm-hmm.
He had a group of, there were good people on that committee. They came up with ideas about how you exchange health information. Rios, you remember Rios?
Mm-hmm. Yeah.
And then when Obama got elected, he appointed a new committee, and they threw everything away.
Mm-hmm.
And so to be in the middle, I couldn't. It was really stressful. And so I remember going to the woman who ran it, and I said, you know, I don't feel like I'm contributing anything here. I'm having an impact. And she said, stop right there. You come to every meeting. You know, you're here all the time. You need to be. You know, you cannot resign. That's what she said. But eventually I resigned. So anyway. So it'd be interesting to think about how the policy could have been done better.
Well, and I think one of the things that's actually going to drive the continued reliance and growth of electronic medical records, health records writ large, will be these reporting requirements. As they continue to add reporting requirements, many health systems, in order to attest to meaningful use, were actually compiling a lot of this by hand and generating reports to satisfy the reporting requirement.
And at a time when we're trying to cut healthcare costs and reduce reimbursement, to add this on to health, it wasn't wise.
Yeah, it would have been, more time would have been helpful.
Yeah.
So,
Yeah. Well, okay. You're saying that. So what they were worried about was, you know, we were racing through things, and the reason was because they were worried that the midterm elections, that the HITECH Act would, you know, that we'd have a Republican Congress and it would stop the HITECH. So whenever I would say that, right, you know, not thought we don't have time, they would say, you know, we have to get, basically it was, you had to get it through before the midterm elections. So,
Yeah.
anyway. But that's enough.
Sure.
So I'm sure others have thoughts and ideas. So Paul, you have to use the mic or it won't get on the podcast.
Thank you for that great talk. By the way, I grew up in a 203 area code, just want you to know.
All right, there you go.
I only know enough about this area to be a little bit dangerous, so in learning about it for a project we're doing, we've heard that innovation is often stymied by laws, especially laws concerning privacy. And we've also heard, on the other hand, that those laws aren't good enough because the privacy only extends to health organizations, but other organizations can buy data and they can essentially reconstitute the data so that the privacy protection is lost. And I just wanted to get your comments and thoughts on those ideas, which, as I mentioned, may or may not be correct.
Oh, sure. So one of the big ones, HIPAA, the Health Insurance Protection and Portability Act, is often cited as essentially saying we can't share your data, potentially even with you, in some instances. And I don't think HIPAA actually says much of what we choose to believe, and this is where the compliance officers and risk management folks will suddenly appear. How they know we're holding these meetings, I don't know, but they come out of the woodwork and will tell you that you're putting us at risk, and that's often stymied that. So I do think HIPAA was written, mostly, by the way, it was really focused on COBRA benefits and ensuring portability. The privacy thing was sort of a tack on to that, and it's been misconstrued, and it's also a little bit out of date. They really didn't anticipate the internet and electronic medical records, and yes, there's some need for that. The other loophole that you're alluding to is the business associates agreement. So anybody we have a BAA with, and that can be a lot of people here, a business associates agreement, anybody we're doing business with on a sort of contracted format can often get all of that data just open, and yes, how they may use that is not well controlled or well regulated at all. That's actually one of the areas they probably need to fill that hole a little bit. The other part that's very disturbing, and Dean Clegg mentioned, is the lack of sharing. If we're ever to realize the big data hope of addressing disease through the information, we've got to be able to share this with researchers. And it's at the point, I do some work with Ohio State, and they've created a data warehouse, and their hope is to monetize their data warehouse. they've essentially shut off all their researchers from even their own health system at this point. And it's really a troubling, not only, so it's that bad in some instances, but we're not realizing the hope of being able to share across, and especially with things like cancer treatments, where cancer is many things, and you often have very small cohorts. To be able to collect all those instances together is absolutely essential to making these gains, and all of those things are on the table. And I don't see any appetite for addressing it, though, anywhere.
Well, so Kellogg first, Becky Kellogg, and then I'll give this to Doug.
Great, thanks. Very interesting talk. One of the things that comes to mind is, what about the rest of the world? Is there something that we could aspire to that is showing success, or is this constantly going to be this challenge of not quite getting it right? And on the flip side of that, is privatization going to be the solution? If we did ship this all out to Google or Amazon and said, take care of it, would they have a better outcome?
As I said, so two parts. I'll answer the second part first, which is what does it take to get the technological advances moving. I do think this is an area that's could be very fruitful research. And Johns Hopkins, particularly with our computer science folks down the road, who are the world's leaders in artificial intelligence and machine learning, and natural language processing is actually the third leg of that, where they read a text and they can have the machine interpret that text and then put that into fields that are structured in a way that we can analyze. I do think that would be the sort of area where investing in research would be very fruitful. With that said, a lot of people are working on natural language processing, machine learning, and artificial intelligence for other applications, and it'll probably spill over back the other way into healthcare, including people like Google. Google's actually relaunched their programs to look into personal health records again, so they are entering back into that field. You'll see that. In terms of the international settings, in places where they have single-payer systems, you'll often see that the data gets shared more freely. It's also a cultural sense when you're particularly the Scandinavian countries, where they view themselves as being part of the community and that the data is open to all to some extent. They much more liberal sharing policies around that information. I think that parts of the European Union are ahead. Australia, New Zealand actually are fairly far down the line in some respects, in some parts of those countries. Umbria, of all, Italy, I don't know why. One of the places that's very good. There are pockets of it. Yeah, we should definitely go to Umbria, yes. But yeah, there's, and often the same vendors that are here are there: Siemens, Cerner, Epic.
Two things. First, I want to applaud Dean Clagg for
This is not good.
for revealing his traumatic experience, and I'm hoping that was therapeutic for you, Mike.
Well, let's talk about HIPAA.
But Eric, can you go back to one of your slides? It was that one.
Mm-hmm.
So what are those hospitals in stage 3 going to do? It looks like they're going to. Where are they going? It's not like they're going to take their digital wall phone and go back to a candlestick. You have something like 1,000 to 1,500 hospitals moving off of of stage 3, but they don't seem to be going anywhere.
Sure. So I guess the disconnect that I haven't made clear is most of these are still driving billing systems. And they're going to maintain stage 3 because that actually completes most of their required forms for billing. So my suspicion is that's why they're going to stop and probably stay there. And as I said, depending on how the billing folks behave in terms of demanding more reports and more detailed information, may very well drive them down into the next later stages. It remains to be seen. The insurance companies. So the other thing that I didn't say also, the lobbies have gotten very good also. The American Hospital Association, the American Medical Association, Medical Group Management Association, all geared up their lobbies and have been pushing back hard in the places where they can. You know, nobody donates more money to Congress than healthcare interests, and the insurance companies are not particularly keen to have a lot of this information and be held accountable for their population's health in those ways. So there's a lot of resistance in a lot of quarters that are well lobbied to stymie this.
So Peter, did you have your hand up? No. No. Okay, good. So, well, let me take that. So I think, we have a reception outside where we can talk and be more frank about our feelings about that. But I think it is, it was great to hear this, your paradigm for innovation. I think what's sad is that there's great hope of what health IT, well done, could do, right?
Yes.
At a population level, at a management level, and hope it would increase efficiency, increase safety, when in fact they were kind of naive associations, and so there is, I think, a great need to sort of hone this model, hone these models and do it right. But it's the problem of our multiple systems of healthcare, isn't it?
It is.
I mean, it's just a and they you said it well about we could have some really spirited discussion about these things.
Well, and the good news is there are organizations like our own,
Yeah.
and places like Kaiser that you hear a great deal about, Intermountain Health,
Yeah.
Geisinger. And Kaiser in particular is having remarkable
Yeah.
success
Yeah.
and are actually demonstrating it. And I think when they start to move markets in California,
They drove down mortality from coronary heart disease 25%, and that's epic. Right?
yeah.
That's epic.
And they are an Epic user,
They're
yeah.
Epic, yeah.
And they're actually big enough to have some influence with
Yeah.
Epic
Yeah.
as a purchaser.
Well, please join me in thanking Eric for this.
Thank-